these. So y'all can all see that over there? Okay. So I know Dr. Temple said she sent out a Blackboard email saying to be prepared for today's class. We're going to have some discussion and review questions throughout. But we are going to start with a pre-quiz, and we're going to have a post-quiz after, and that's just to evaluate the level of knowledge that took place and learning that took place with today's class, and that way my teacher will be able to evaluate me. Okay? So what we're going to do next is we're going to do just a little group activity at each table. These are scenarios that if you look through the chapter and did the reading, you should be able to get a good idea of what. So this is the lecture on alterations of neurological function in the pediatric population. These are the objectives that you should be able to, by the end of class today, be able to do. Identify the most common neurological conditions in pediatric patients. That's including diagnostics, clinical manifestations that you'll see on the floor, as well as treatments. You will be able to differentiate between the adult and pediatric neurological anatomy. We'll do a little activity, and so you should be able to differentiate between bacterial and viral meningitis. And then we'll talk about the different types of seizures that are common in children, and you will be able to differentiate between those. And then at the very end, we'll practice some nursing diagnoses on neurological conditions discussed today. Okay? Are there any questions? So first we'll talk about some differences in anatomy. The brain and the spinal cord are formed very early on in gestation, and so this is important to remember because if there's any kind of infection or trauma during pregnancy, this will affect the development of the infant. The cranial bones and vertebrae are not completely ossified, and so this is important to remember as well because we've all seen infants had how they're much larger compared to the rest of their body, and so this can lead to greater risk of injury from trauma, so we have to protect their head and protect their neck because their neck is weak until their body can grow into it. All infants have the fontanelles, which is the spaces of connective tissue covering the brain at the junction of the skull bones. And there's the anterior and the posterior fontanelle. So the anterior closes anywhere from 18 to 24 months of age, and then the posterior closes around 3 months of age. When the child is around 8 or 9 years of age, that's when the spinal cord reaches the adult characteristics, and then around age 12 to 15 is when the brain reaches its full growth. So this is a picture showing what we just talked about. You can see how much larger the infant's head is compared to the rest of its body, and it has the sutures there as well as the fontanelles. Okay. So to assess an infant or a child, you want to look and see if they're lethargic and difficult to arouse. Are they irritable and difficult to calm and console? You'll look at their score on their Glasgow Coma scale, which we'll go over that. You'll palpate the fontanelles. Are they sunken? Are they bulging? These can indicate the level of the intracranial pressure. Checking their pupils. Are they equal, round, reactive to light? I know I was in clinical with you, some of you, a while back, and you were saying how difficult, I can't remember who it was, how difficult it is to assess the eyes of an infant because you can't exactly tell them to open their eyes, but if you actually sit them up, and their eyes will automatically open for you. Kind of like, you remember those baby dolls? Mm-hmm. So just sit them up a week until their body can grow into it. All infants have the fontanelles, which is the spaces of connective tissue covering the brain at the junction of the skull bones. And there's the anterior and the posterior fontanelle. So the anterior closes anywhere from 18 to 24 months of age, and then the posterior closes around 3 months of age. When the child is around 8 or 9 years of age, that's when the spinal cord reaches the adult characteristics, and then around age 12 to 15 is when the brain reaches its full growth. So this is a picture showing what we just talked about. You can see how much larger the infant's head is compared to the rest of its body, and it has the sutures there as well as the fontanelles. Okay, so So to assess an infant or a child, you want to look and see if they're lethargic and difficult to arouse. Are they irritable and difficult to calm and console? You'll look at their score on their Glasgow Coma scale, which we'll go over that. You'll palpate the fontanelles. Are they sunken? Are they bulging? These can indicate the level of the intracranial pressure. Checking their pupils. Are they equal, round, reactive to light? I know I was in clinical with you, some of you, a while back, and you were saying how difficult, I can't remember who it was, how difficult it is to assess the eyes of an infant because you can't exactly tell them to open their eyes. But if you actually sit them up, and their eyes will automatically open for you. Kind of like, you remember those baby dolls? Mm-hmm. So just sit them up and they'll open for you. It should be a little bit easier to assess them then. Checking their vital signs for anything abnormal, widened pulse pressure, checking their respiration, their pulse rate. Again, indications of what's going on with their intracranial pressure. And then assessing their pain. So, are y'all familiar with the Glasgow Coma scale? Have y'all used that? Yeah? Mm-hmm. Okay. So you know, it's looking at the eye response, verbal response, and the motor response. So you just tally up the score in each section and then get the total. So 3, the child would be in a complete comatose state, and 15 is the normal score. And then this is FLAC and FACES. FLAC you use for children less than 3 years of age, just looking at their face, if their legs are kicking and how active they are, their cry and how easily they can be consoled. And then with the FACES, this is used around 3 to 7 years of age, and what you would do is have the child point to the picture that best depicts, you just ask them how bad your pain, have them point, and then that's the pain scale you would give them. And then once they reach the age of 7, or once they can comprehend the numeric scale, we can use that. Okay. So who had the picture of this little girl? Can somebody just read that aloud and tell me what you thought?
You work at an outpatient rehab facility. Your favorite patient is here for her weekly PT, OT, and speech sessions. She is 7 years old and wheelchair bound. You know that she was a preterm infant and was only 5 pounds when she was born. What is her diagnosis? We said cerebral palsy.
Okay. Is there anything in particular that clued you into that?
Her speech and that she was wheelchair bound and that she was like preterm.
Perfect. That's what I was looking for. Thank you. So right, cerebral palsy. So your book defines cerebral palsy as a group of permanent disorders of movement and posture development causing activity limitation, which is attributed to non-progressive disturbances that occurred in the developing fetal or infant brain. So key here, it is non-progressive, meaning it doesn't get worse over time, and it mostly affects movement and posture, and it's developed either in utero or early infancy. So there's 5 major types of cerebral palsy. The first is spastic, and this is the most common type. And with this, the child would have exaggerated reflexes and their muscle movement is very stiff. With dyskinetic, that's the second type, and this is divided into 2 different categories. The first is atheoid, that's spelled A-T-H-E-T-O-I-D, and this involves the involuntary slow movement of the extremities. And then dystonic is the second type under the dyskinetic, and that's when the trunk movements are twisted, so they kind of have like a twisted posture, is how they would present.
You said dystonic?
Mm-hmm. D-Y-S-T-O-N-I-C. The third is ataxic, and that's when the voluntary muscle movements are not very well coordinated. The fourth is hypotonic, and that's when their muscle tone is floppy and decreased. And then the fifth would be mixed, and that's just if they would have any combination of any of those. So here's some risk factors that you would see for a child with cerebral palsy. If they're born with a low birth weight or if they're born premature, if there's a prolonged or traumatic delivery, prenatal drug exposure or infection. If the infant is born as a twin, triplet, quadruplet, that could increase the risk. An anoxic birth, intracranial hemorrhage in infancy, preeclampsia or antepartum hemorrhage, and the mother and fetal distress and neonatal seizures all increase the risk. However, with all these risk factors, about 80% of all cerebral palsy is from unknown causes. So these are some clinical manifestations that you'll see. Again, affects the motor, the development, performance. They'll have those abnormal movements, the alterations in the muscle tone and the postures, and then the reflex abnormalities. So, unless an infant is born with any of those risk factors that we just saw a couple slides back, kids with CP are normally not diagnosed till around 1 to 2 years of age. And it's normally the parents would notice as a kid starts walking or potty training, they would notice an ataxic gait or problems with bowel and bladder function. And so that's when they would bring them in and they would work them up, and then they would be able to diagnose it. But those kids who have the risk factors are followed very closely from infancy. Okay, any other questions on that? No? Okay. So whoever has the ball, you can throw it to somebody else. Craniosynthesis. Yeah, so what's the major difference?
That's where the sutures close early,
Uh-huh.
and it affects the brain growth and brain shape and head shape. And microcephaly is when you have a small head and a small brain.
All right, awesome. All right, so who has this unhappy little guy?
Oh, he's so cute.
You're taking care of a 1-month-old infant who was brought in overnight because his mother states he was very irritable and would not stop crying. He had a decreased appetite the day before and emesis ×1. He has a bulging anterior fontanelle and the NP has ordered a LP. What is your patient's diagnosis? And we said bacterial meningitis.
Awesome, yes. So yeah, that leads us to intracranial infections, and we'll talk about meningitis and encephalitis. So meningitis, that involves an inflammation of the meninges, which is the lining of the brain, and it can be bacterial or viral in origin. So bacterial meningitis, this is a medical emergency because it can become fatal very quickly. There's different organisms that can cause bacterial meningitis, and basically the age of the child or the infant, different bacteria are associated with that. So if we look at the pathophysiology, you can kind of get an idea as to why it's so fatal. And this does very quickly. So the bacteria enter the blood supply either through a pre-existing infection such as a sinus infection or cellulitis, or even if the kids are getting a lumbar puncture for whatever reason, that can present the bacteria into the system that way. It's disseminated, and so it spreads throughout the body, including the meninges. And so this causes the inflammatory process. We'll see the increase in the white blood cells, and that forms an exudate around the surface of the brain. And then if it progresses far enough, pus will begin to develop in the ventricles. And so that's why it's just so important to act quickly if you suspect, or if bacterial meningitis is suspected. And so these are some clinical manifestations that you would see. Infants typically have nonspecific signs. Irritability is the most common, as well as the bulging fontanelle like we saw in that little scenario. But they could be lethargic as well. They may or may not have a fever, vomiting, seizures, a high-pitched cry, and the nuchal rigidity is also key for meningitis. In toddlers, they have a more gradual onset of symptoms. They will present with the neurological symptoms, but they'll also have upper respiratory and GI symptoms as well. And then in children and adolescents, they have more of an abrupt onset. They'll have the fever, chills, headache, and the stiff neck. Vomiting, changes in their level of consciousness, seizures. With the meningococcal bacteria, that has a petechial and purpuritic rash associated with that, and we have a picture of that, as well as all meningitis is positive for Koenig's and Brzezinski signs. So there's a picture of what the petechiae and purpura look like. Petechiae are the smaller lesions and the purpura are larger, so that's how you can differentiate between them. And this is caused by just bleeding under the surface of the skin, and it occurs in patches throughout the body at a 90-degree angle at the hip and try to bend their knee. And what would happen is they would experience severe pain in their buttocks and upper thigh region. And that's caused from the irritated nerve roots going through those inflamed meninges is what causes that. And then with Brzezinski's sign, when you flex the neck, their knees will automatically flex up, and again, that's caused by those the inflamed nerve roots and the inflamed meninges. So, does that make sense? Koenig's is with the lifting of the leg, and then Brzezinski's is the lifting of the head. And so to get a diagnosis of meningitis, a lumbar puncture is the most definitive way. You would see an opening or an elevated opening pressure with that, and you want to culture the CSF to determine what bacteria is causing the infection. And it's also important to get a blood culture as well, because sometimes for whatever reason the bacteria may not show up in the CSF, but it'll show up in the blood, so the child will be septic. And so you would need to do that, yeah.
What's opening pressure?
That is the pressure that, okay. Do y'all know what lumbar punctures are?
Yeah.
Okay. So when you go in, immediately, right when you put the needle in, sometimes the CSF will kind of squirt out. Treatment is supportive until the symptoms resolve. Just managing the symptoms. Okay. I hope this works, guys. This is what we were having problems with. So, get out your phones. Have y'all done this before? No. Okay. So, we're going to compare and contrast bacterial versus viral meningitis. So, I want you to text in. You're texting to the number 37607. And first what you would do is type in that top number, 433653, and then space, and then type in your answer. So either text in a similarity, a big similarity, or a big difference between the bacterial versus viral. Does that make sense?
So the number you gave us.
So the number that you're actually texting to is 37607. And then for your message, first you'll type in 433653 space and then your answer. I got some. Okay. Awesome.
What was the question?
Text in either a similarity or a major difference between bacterial and viral meningitis. Awesome.
Ooh, this is cool.
So, viral here. Bacterial. All right, yeah, bacterial is a medical emergency. That, yep. So, yeah, antibiotics. Nice, bulging fontanelles, yep. Okay.
If it won't send, is that like?
If it won't send, I don't know what to tell you.
Type the number.
Yours didn't go through? There may be, because it limits itself to like 40 responses, so we may have hit that limit.
I don't think we have 40 people though.
I don't know. All right.
Table. We do it.
Can y'all share?
While changing your 5 medical patient's diaper, you notice a small dimple and patch of hair on her lower back. What would this be indicative of? This is spina bifida.
Awesome. And there are actually multiple types of spina bifida, so we'll talk about each of those. So this leads us to the neural tube defects. So when the spinal cord is normally being developed, it's encased by the spinal cord is encased by the vertebrae and the neural tube. And so when there's a defect for whatever reason, infection, trauma, anything like that in utero, this can lead to a neural tube defect. So there's varying degrees, and we'll talk about each of these in greater detail. Etiology for neural tube defects, primarily unknown. This is one thing you'll kind of learn in medicine, they don't really know, but there's a genetic and environmental origin to pretty much everything. But it is thought that using folic acid during pregnancy and even up to 1 month prior to conception, the 0.4 milligrams daily, is thought to help with the decreasing the development of neural tube defects. And so this is a picture of the baby's spine, and I'm just showing you this so that you'll know that the higher up that the defect is, the more neurological deficit that's associated with it. Okay, can you read that?
You're taking care of an 8-year-old patient who is scheduled to have an EEG today. He appears healthy. Your patient tells you how much he likes school, but he is upset because his grades are dropping. He states he has been zoning out a lot lately and he has been more tired than usual. What does the medical team suspect may be wrong with him? Absence seizures.
Great. All right. So yeah, now we're going to talk about seizures. And there's a bunch of different kinds: febrile seizures, epilepsy, and there's many different under those. So we'll talk about each of those, as well as status epilepticus. So first, febrile seizures. These are seizures that occur with a rapid rise in temperature, and these typically occur between 6 months and 3 years of age. They can be clonic or tonic-clonic in nature, and there's also simple febrile seizures, which last less than 15 minutes, or complex, which lasts greater than 15 minutes, or they're recurrent, meaning they happen one after the other after the other. Treatment for this, airway, breathing, circulation is very important. IV or rectal diazepam only for if the child is having the prolonged complex seizure. Otherwise, you want to stay away from that. And then controlling and identifying the source of the fever, because if you can, identify the source and treat that, hopefully you can help prevent the seizures. So epilepsy is a chronic condition, and this is when the child has 2 or more unprovoked seizures. Most of these are idiopathic in origin, although. So this is where we begin to break it down into the different categories. There's partial and there's generalized and unclassified. So partial is when the seizure is limited to a particular area of the brain. Normally it's like the frontal, parietal, or temporal region are the most common. And so the symptoms that the child is having is associated with whichever area of the brain is being affected. And these can be simple or complex in origin. And then generalized, that involves both hemispheres of the brain, and with that the child would experience a loss of consciousness and uncontrolled motor movements. And then unclassified, which we'll talk about, and that's a seizure that fits into neither one of those categories. And so partial seizures can further be broken down between simple partial and complex partial. And so with simple partial, this is when a child has simple symptoms with no alterations in their level of consciousness. And then complex partial is when there's more complex symptoms and there may be an impairment in the level of consciousness. And then simple or complex seizures that are secondarily generalized occur when a simple or complex partial seizure evolves into a generalized seizure. I know that's wordy, and there is a picture on the next slide to kind of help make sense of that a little bit more. So here is a video of the simple partial seizure.
कितने घंटे से है ये? पहले भी कभी हुआ है क्या इसको? पहली बार हुआ है? घर में किसी और को तो नहीं होता?
Is a simple partial seizure something where a child, okay, so the child's alert,
Yes.
they're able to do things, but they don't have control over that motor?
Right. It's just, yeah, that particular, and it's normally very subtle like that. Either maybe like a twitching of the arm, twitching of the mouth.
So what makes that different than like a tick or something?
Like, are you talking about associated with maybe like Tourette's?
Like Tourette's or something, yeah.
I think it's just the circuits in the brain. I'm not exactly sure.
Yeah, okay.
But yeah, there is a difference. Okay. Okay. So this is a picture of what I kind of talked about, the secondarily generalized. And so what that means is, first, the seizure will start out as a partial seizure, kind of like what we saw in the video, just with the mouth twitching or something. So with a generalized seizure, the child would experience a full loss of consciousness. It can be, it's tonic-clonic, and this was formerly known as a grand mal seizure. So first, they'll have the tonic phase, and that lasts anywhere from 10 to 20 seconds. And this is when you'll see the rolling upward of the eyes, the immediate loss of consciousness, and this is followed by the flexion of the arms and legs and neck extension. And then the clonic phase follows after that, and that's can last anywhere from seconds up to 30 minutes. And that's the jerking movements that you would see of the trunk and the extremities. And during that, they would have some oral secretions, maybe some involuntary loss of urine or feces. And so the important thing is just gotta let them seize and just turn them on their side and let them seize. After these seizures, these kids typically have what's called a post-ictal period, and it's just really hard to arouse them after that or during that. So we have a video here what that looks like.
Baby.
So there's just another picture there showing the tonic phase and then the clonic phase. Okay, so then an absent seizure. These were formerly known as the petit mal seizure, and this is what our little guy in our scenario had. So with this, they'll have a brief loss of consciousness with minimal or no alteration tone. So they just kind of zone out. And this typically occurs during school age, so it can affect their grades sometimes. And then even some kids, they can, during their absent seizures, they're able to still hear what's going on in their surroundings. So sometimes if you ask them, they can repeat back what they heard during their absent seizure. So here's what that looks like.
Even though you're absent, she sent me the homework that when I was absent.
Do you know what you gave me again?
Okay, so who had this picture? Yeah. You want to share?
You are preparing your 1-year-old patient for surgery today to get an EVD placed. She is irritable with a bulging anterior fontanelle, sluggish pupils, and vomiting. What is she presenting with? And we said hydrocephalus.
And I have actually seen hydrocephalus more severe than that. So, yeah.
That was like amazing. It was amazing.
Yeah, I don't know. It's sad though. And they couldn't figure out what was causing the hydrocephalus, so it's just sad. So hydrocephalus is actually, it's hydrocephalus, that's right. You will probably see this pretty commonly because it's a sign and a symptom associated with something else that's going on. And it's caused by disturbances in the CSF flow. Either something that's causing an increased production in the CSF, causing an impaired absorption, or a block in flow. And it can be congenital or acquired. So congenital spina bifida is an example of that. Acquired would be intraventricular hemorrhage, meningitis, a tumor of some sort. Any of those can lead to the development of hydrocephalus. Okay, so there's two different types. There's communicating and non-communicating. Communicating is when the CSF is able to flow freely between the ventricles, but for whatever reason there's an impairment with the absorption. And then non-communicating, this is the most common, and this is caused by an impediment of the CSF within the left is the normal, and then on the right you can see how enlarged their ventricles are, and then leads to that bulging fontanelle. And so here's some some conditions you could see with causing the acquired hydrocephalus: intraventricular hemorrhage, meningitis, a myelomeningocele, tumors anywhere, or any type of head injury. And so some clinical manifestations that you would see in infants, they will have that abnormally large head growth. You'll see the tense or bulging fontanelles. Frontal bossing is that enlarged forehead that you see. The setting sun sign is when the iris is visible above, the sclera is visible above the iris. Mason sign is when you would, if you percuss the skull, you'd hear like a hollow sound. And it is important to remember that, so infants, they still have their sutures are still closing, so they have more room to kind of expand. But once the child gets older, and if they begin to develop hydrocephalus, they don't have that room, and so they begin to develop symptoms much quicker. This little girl has probably had it since she was an infant. That's why her head is so enlarged. And so here's some early signs that you would see: changes in the level of consciousness, vomiting, they could be irritable or lethargic. This is commonly done with a shunt that is placed by neurosurgery, preventing any complications such as infection or seizures, and managing secondary problems such as weakness or spastic movements. So when these kids go to surgery, first they would need to have any space-occupied lesion removed, such as a tumor or a mass. VP shunt, a ventriculoperitoneal shunt, is placed for infants and smaller children, and these have to be changed out as a child grows bigger. And then a VA shunt is placed, that's a ventricular atrial shunt, and that's placed in older children or adolescents, and it's contraindicated for kids with cardiac disease.
Why is that?
Because it is, the shunt is going into like the atrium.
Oh.
Yeah.
So if you put a VP shunt in an infant and then they have a cardiac disease, what do you do when they get older?
Say it again. VA shunt?
A VP, if you put that in an infant, but you can't have that when you get older.
Like if they have.
Oh, you can have a VP shunt as you get older.
Oh, okay.
VA shunts, okay, no, yeah, it's not necessarily once you're a certain age you have to have a VA shunt. I've actually never seen one. I more commonly see the VP.
Okay.
Surgeons are a little wary of doing VA shunts just because, I mean, really? So this is what it looks like, and this is all internal. So fairly simple surgery compared to most. So the surgeon makes just 3 small incisions, one in the scalp, one kind of at the clavicle, and one in the abdomen. So he places the shunt in the ventricle and then shoves that tubing down into the peritoneum. And when he places it, he sets it. So, okay. Your normal intracranial pressure is 20 millimeters of mercury. Your ventricles hold about 25 mLs of CSF. So when he places it, or she, they will program it to open once the intracranial pressure reaches a certain level. And so once it reaches the programmed level in this child, the shunt will open and the CSF will flow down that tube into the peritoneum and then be excreted. Does that make sense?
So the kid will just poop it out.
Pee, yeah.
Okay. And
Or
then,
sweat,
and just that's just how it comes out.
Mhm.
There's not a risk of like an obstruction at all. This is just.
Sometimes it could, yeah. I mean, and we'll kind of talk about it in the next slide. I mean, there's multiple reasons because I've had a lot of kids that I had with hydrocephalus. They would come in frequently to have, yeah.
How long are they on it?
It depends. I mean, some kids have these for several weeks, up to a couple months. It just depends on what's going on. Some kids, if there's like home health nursing involved, then you can teach the parents. They can go home with them if there's still something going on where they can't have it internalized. So, yeah. So post-operative care, surgeon will indicate the position or the level that it needs to be draining at, keeping the child flat, and then slowly raising the head of the bed over time. In the infants, you would need to measure their head circumference daily to make sure, again, if the shunt clots off or anything, you would be able to detect that if they were having an increase in head circumference. Observing for the signs and symptoms of increased ICP that we talked about. Strict intake and output measurement, monitoring their respiratory status, and monitoring for any signs of drainage or infection at the surgical sites. Okay, we have another review question. Whoever has the ball now, I don't know where it's at. Okay. Oh. 20, okay, yeah, that one's pretty easy. Okay, so who has, I think this may be our last. So, migraine headaches, idiopathic in origin, although there are thought to be genetic factors associated with it. It is typically disabling, recurring, and frequently occurs on only one side of the head. Migraines can last anywhere from 4 to 72 hours, and there's often associated symptoms with them, such as the photophobia, nausea, vomiting, and even, I guess, sometimes an aura. People can have those. Triggers, fatigue, if the person's fatigued, that can trigger a migraine. Bright or strobing lights, changes in the weather, or even stress can trigger a migraine. And so I found this mnemonic that I thought would be helpful in remembering the symptoms. It's Sultan's. And so, is the headache severe? Is it unilateral? Is the patient sensitive to light? And is the headache throbbing? Does it worsen with activity? Is the patient nauseous? And are they sensitive to sound? That can help you remember that. And then tension headaches is the most common. I think we've all had these at some point. These can last anywhere from a couple hours to even a couple days. Presents as a mild dull pressure, and it even can radiate down the neck into the shoulders. Common causes for this: striving for academic excellence, emotional stress, Excedrin, Motrin, and then I think there's even a migraine option for all of those. Propranolol and valproic acid can also be given if the child requires a prescription for their headaches. And then if they experience nausea, you can give them medications for that as well if they need them for migraines. All right, so any questions on headaches? So Pompe disease, this wasn't in your book, but I've seen it in practice and thought it was kind of neat, so I figured I'd share it with you guys. So supposedly it's pretty rare, but then when I was doing some research on it, it's 1 in 40,000 live births. It is inherited and often fatal. These kids typically do not end up living past their first birthday. And what it's caused by is a mutation in a gene that makes an enzyme called GAA. And this affects the glucose production, which then in turn affects the cells of the heart and the skeletal muscles and eventually disables them. There's two types. There's early onset, which is the infantile form, and then late onset is the juvenile and adult form. So with the infantile form, these infants are born with a complete or almost complete deficiency of that GAA enzyme. So some symptoms that you would see, they would have feeding problems, so typically they're not involved. So the way they get a diagnosis for this is screening for genetic mutations or measuring that level of the GAA enzyme. And then once a diagnosis is made, all the other family members are tested to determine who the carrier is. And since this affects multiple systems of the body, many specialties are involved: cardiology, neurology, respiratory therapy, physical therapy. Enzyme replacement therapy is done, and there have been many clinical trials. So 2 drugs recently approved by the FDA for Pompe is Myozyme for infants, and the patient that I had actually was taking Myozyme when it was in its clinical trial. She was one of the first to take it. And I guess it works very well because she's 5.5 now, and from what I hear, she's still doing very well. And then Lumazyme is given for the late onset form. So prognosis for this depends on age of onset. If they're diagnosed later, the disease would progress slower, and so a little bit better outcomes for them. So any questions on that?
Are we going to need to know that for the test?
That's a question for Dr. Kimball's. I don't know what she said was on there. Diagnoses. I want y'all to get into pairs and come up with just 1 or 2 nursing diagnoses on anything that caught your interest in today's class. Okay? And this is just for practice, so you don't need to turn them in. Oh, thank Y'all have done nursing diagnoses, right? Okay, I thought so. Just type.
What?